All of you know that cold or common cold is a very common problem. Winter is coming and even but it may be common. It's not simple. Many of us know the commonest cause of death in most of our asthma, COPD, coronary artery disease, diabetic, malignancy, HIV, and elderly patient is common cold. It starts with an influenza infection, goes to bronchitis, pneumonia, multi-organ failure, septicemia, and death. If you track most of the ICU patients today, they are respiratory infections, and most of the respiratory infection starts from a very mild common cold. And many of us are not conscious of immunizing our patient against this common illness, though we have vaccines as early as we discovered the virus. You'll be surprised. In 1933, the influenza A virus was discovered, and in 1938, the first vaccine has come. The eggshell vest vaccine has come in 1938, just after 5 years. In 1940, the influenza B virus was very low because we are not very aware of this common recommendation. So maybe next 8 minutes I'll show you very relevant data on this very common vaccine, the influenza vaccine, and sorry for taking time from your dinner. The evolution and revolution of influenza vaccine includes the illness, current recommendations, and finally the world's first, the virus-like particle vaccine, which is the latest discovery. We'll start from the history and we'll end at the latest information from the science. All of you know that it enters by a droplet infection, and somebody sneezes in this hall, all of us are in danger of catching cold because crores viruses are liberated with a single sneeze. Then it shuttles in the respiratory tract, starting from pharynx, larynx, sinuses, upper respiratory tract, and finally the lower respiratory tract. Highly contagious acute respiratory illness. We see it in two forms. One is annual seasonal epidemics, which either take place in winter months in temperate countries and year round in tropics like India. We don't know how many times we suffer from. And so far as global pandemics are concerned, occurs in any season and include multiple waves lasting for more than a year. The latest experience of ours was this swine flu pandemic, and around 20% of the population is infected with the influenza virus every year. I think the data in India will be more than that because we are a developing country with many more factors contributing to the infections. Symptoms I need not tell you. Complications also, you know that it can lead to otitis media, sinusitis, pneumonia, and acute exacerbation of asthma, COPD, and just decompensate anybody with a chronic illness. You'll be surprised to know that in 1918 and 1920, just after the First World War, a Spanish flu could take as many as 100 crore lives. 100 million people died of a H1N1 pandemic. You have seen pictures during our swine flu pandemic in last 2010, where 18,000 people were infected and it was declared pandemic, but because of the prompt actions, it was controlled very fast. The same notorious H1N1. What this H and N stands for, all of you know. H is hemagglutinin and N is neuraminidase, two capsular proteins. And besides these two, there is another protein called M1 in influenza A virus. Influenza B virus has a common protein. So what we target is this H1N1 and the B virus protein for preparing a vaccine. And you can see so many people have died in the world history because of a simple disease like influenza or flu. Which viruses? All of you know the A, B, C. There are three types of viruses, A, B, C. C, we are not much concerned. A very docile virus, hardly causes infection, and we don't have vaccine for that also. A virus is notorious, as I have already told you, infects humans, animals and birds. And we know the bird flu, the human flu, the swine flu, etc. Responsible for annual epidemic and pandemics, classified into different subtypes and strains based on hemagglutinin, which ranges from H1 to H17, 17 types, and neuraminidase N1 to N9, 9 types. And the infection in human is typically caused by the viruses displaying H1, H2 and S3 and N1 and N2. These 5 strains are notorious for our infections. B virus for responsible for annual epidemics but not pandemics. Pandemic is again by the A virus, and their two types are Yamagata and Victoria, and I am not going to the details. C, I is told, is a very docile virus. Who should receive? The CDC, Center for Disease Control Atlanta, United States, recommended everybody, all healthy persons aged 6 months and onward. But WHO has specified people at high risk of influenza and related complications like adults including pregnant women, children with chronic conditions like respiratory diseases, asthma, COPD, coronary artery disease and heart failure, diabetes, metabolic diseases, malignancies, chronic renal disease and liver disease, immunocompromised patients like HIV patients and other chronic illness, elderly patients. Professor Maharana is here, his population, elderly 65 years and onwards, pregnancy of course a immunocompromised state, and children from 6 months to 59 months, that's around 5 years or below. Below 6 months we don't have much trials and we don't know the immunogenicity of this age group. This is the classical recommendation, and I'll tell, recently 2 days back I was in Lucknow and we released a RSSDI guideline for type 2 diabetes management, and I have contributed for the vaccination, and it is accepted unanimously that along with the pneumonia vaccine, the influenza vaccine should be given each year to each diabetic irrespective of their immune status. That can prevent their infection, and this has been unanimously accepted and published. The seasonal influenza vaccine, the international recommendation by WHO will see, they not only include patients, they also include people who transmit the virus like healthcare workers, both to prevent sickness and to prevent spread to patients, patient to patient spread through the healthcare workers, women at all stages of pregnancy, breastfeeding mothers, they infect their children, and household contacts of persons in high risk group. Suppose you have a maid servant taking care of a person who is bedridden, and the same person can infect that patient, so that the caregivers are to be vaccinated. This is a seasonal Indian recommendations. You can see that it's not there in universal immunization program. Government is not included because government has to give it free of cost. So we have recommendation from Geriatric Society in elderly, and from FOXY in pregnancy beyond 26 weeks, maybe 6 months after, maybe in 3rd trimester, all women with pregnancy should be given a single dose of influenza vaccine. The Ministry of Health and Family Welfare has recommended for healthcare workers, and anybody working in a hospital can demand it from the authority. By Indian Academy of Pediatrics, all children with risk factors and were vaccinated and desired and requested by the parents. Many parents are skeptical. Even if the pediatrician doesn't think that their children should take a vaccine to prevent their absence in the school or the problem in the examination. Benefits. Is it really beneficial? Yes, the literature says the influenza related pneumonia decreased by 60%, related hospitalization by 50%, as much as 77%, and death by 75 to 80% by this vaccination. Already have detailed. The reduced likelihood of developing influenza, requiring a medical visit, it comes down by 60%. And the severity of disease also comes down in people who have taken the vaccine, and that is reduced likelihood of transmitting the infection to others. That's very important, because you must have seen if in your family somebody has contracted the infection, it goes around and infects others. Then finally, before I conclude, I'll take 2 minutes. One is evolution and one is revolution. I've already told you, 33 we discovered influenza type A virus, 38 came inactivated monovalent influenza A virus vaccine. 40 we discovered influenza type B virus, and 42 saw the first bivalent vaccine developed. But thereafter it took a long time, up to 78, when the trivalent vaccine with 2 influenza A and 1 influenza B strain introduced. The present vaccine which you see in the market, many of you have taken during the last season also, when there was a hue and cry of swine flu. They contains 3 strains, 2A and 1B. 38 had first, this is regarding the technology, 38 had first egg-based vaccine, 2007 had first cell culture vaccine. After 70 years, from egg-based, from Madame Curie to the cell cultured, 2007 took us 70 years, and now after 6 years we have first insect cell culture vaccine approved by US FDA. Let us see the revolution. We don't target the virus anymore, because in an immunocompromised patient, even if you are giving an inactivated virus, at times, if the processing is not well, it can cause infection, as seen in the tuberculin test. So we target the virus-like particle, VLP technology, very innovative, not vulnerable to variation in egg supply, because egg is not dependent. It involves construction of VLP, the virus-like particle. It is a nano-sized particle which mimics the external structure of the virus but lacks the intact genetic material. This is what a VLP is. We have the capsule, we have the capsular protein against which we prepare the vaccine, but the genetic material is not there to infect. So we can take it as a immunological mimicry. The cells, insect cells, are infected through the virus like particle, not the virus. And it's more rapid. In 3 months' time we can develop the vaccine, producing new strains than egg-based vaccines. And the VLP-based hepatitis B and human papilloma virus vaccine is already in use. They are how promoting our own vaccines. So just few slides on how VLP is constructed. I've already told you the genetic sequences encoding vaccine antigens are selected and synthesized. Genes are cloned into the baculovirus. Baculovirus infect the insect cells, and the VLP is debarred from the cell membrane and are concentrated and purified. The most important thing you see, the VLPs mimic influenza virus. In an influenza virus there is H and N spikes, same as VLPs. M1, same as VLPs. But the RNA genome which is there in the influenza virus is absent in case of VLPs. So contain all 3 proteins and is non-infectious because it doesn't contain the genetic material. And the VLPs can be designated to match the individual viral strains, and time from the strain selection to production is only 3 months. So very early, less labor, less intensive, it ensures the reliable vaccine availability throughout the world. And still there was a scarcity, there was black marketing during last pandemic, and many of us has faced the music. Even government has the problem of procuring the vaccines for vaccinating the high risk people. 1 minute before I conclude, world's first VLP based seasonal influenza vaccine, which I told the latest technology. You knew how it started from egg cell, how we developed cell culture, how we targeted trivalent, the 2A and 1B, and finally the seasonal influenza vaccine by VLP based technology. It's 0.5 ml single dose, 15 microgram of each hemagglutinin antigen of 2 types of A and 1 type of B is taken. They consist H1N1, S3 and N2 and type B. You must have seen in the vaccine literature these three, which is a recombinant trivalent seasonal influenza vaccine. So already you have seen they contain hemagglutinin, they contain neuraminidase, and they contain matrix protein. Three proteins are targeted. Immunogenicity of the vaccine was evaluated in many patients. This trial shows 450, 0.5 ml IM was given, and it was measured. The hemagglutinin antibody titer was measured on day 0 and day 21. And you can see this structure. I am not going to the details. The first one is placebo. Day 1, day 0 and day 21, H1N1, S3N2 and type B. The upper one is placebo. You can see there is no increase in titer. Lower one is the vaccine. You can see the vaccine has increased significantly the antibody titer of all three antigens, that is H1N1, the S3N2 and type B. So immunogenicity, the seroconversion rates on day 21, if you see all three, there is significant seroconversion in the people who are activated. You can see the first one, the 4, 1.3, 4.7 is the placebo. The blue one is after the vaccine, this VLP1 vaccine. So advantages, safely used, it extracts the genetic match and this rapid production, and unlike the live, it doesn't have the risk of infection and can be safely used in patients with compromised immunity, respiratory diseases like COPD, cardiovascular diseases and diabetes who run a risk after a live vaccine. Indication again remains the same. Active immunization in adults against the disease caused by the seasonal influenza like ours, which continues throughout the year, against type A and type B. Doses I have already told you, intramuscular injection usually in the deltoid muscle, and frequency is very evident once in a year, and every time they take this strain and prepare. So maybe you may not get it on time before the season, but it comes gradually. So the patient moves around few chemists to get it, but once he gets, he is happy and his morale is boosted. So more than the vaccine, he is confident of not getting the infection. Safety I had already told you, is very safe and takes care of most of the required data, but few have headache, nasal congestion, low grade fever, sore throat on the day of vaccination. That is not very significant. And precautions, the moderate to severe illness, we have to see that patient is with or without fever. History of Guillain-Barré syndrome that or AIDP within 6 weeks of receipt of the influenza vaccine are to be considered, and it's contraindicated to severe allergic reaction to any component of vaccine. That's obvious there with all the drugs. Finally, before I conclude, I'll summarize. The first recombinant trivalent seasonal influenza vaccine developed with VLP cell culture technology was in 2015. That is in collaboration with a American pharma, and it's already there for use in the market. It induces the robust humoral responses as has been proved to all included strains. Antibody responses achieved and believed to be associated with reduced risk of influenza and its complications. Its seroprotection rate is almost more than 70% against all three strains, free from egg proteins, safe in individuals with egg allergy, free from intact viral genome. It's non-infectious and very well tolerated by most of the vaccines, and the complications like AIDP or patients having severe infection after the vaccine is almost not there. So we have come to an end, ladies and gentlemen. Few take-home messages before I end. Let us think of our patients who have a chronic illness like diabetes, HIV, elderly people beyond 65 years, pregnant lady in third trimester, or children who have asthma or recurrent chest infections and have sufferings throughout the year. Let us think of vaccinating them with the latest available technique, and because it's based on a trivalent seasonal influenza vaccine and we have a preparation through VLP, chances of risk are very low because it's not a live particle, it's a virus like particle. And with this vaccine, keeping vaccination in my mind, maybe our use can decrease the infection to a big extent, and we can protect the patients before they go for chronic infections, pneumonia, septicemia, multi-organ failure and ICU care, a simple shot, maybe in 200, 300 rupees, can give them a big protection, big assurance against this very common but dreaded illness. Thank you for the time.